Thank you very much. A very good morning to all of you and greetings from Punjab, India. I must thank Dr. Carr Miller for this wonderful conference. About my 8 years experience of mini gastric bypass, as we all know probably by now, it's becoming a common procedure now. It's all about making a long, narrow gastric tube along the lesser curvature and then hooking it to the jejunum at around 200 centimeters. It's also called a single anastomosis gastric bypass or omega gastric bypass. This is our demographics. 42.2 was the average BMI. When we look at 8 years, looking back into the complications, the results seem quite interesting. We had only 2 leaks out of 1,468 patients. And marginal ulcer was diagnosed in 12 patients, which comes to about 0.8%. And bile reflux in 1.3% of the patients. I must emphasize here that in Punjab, the diet is very fresh, mostly vegetarian diet, and the smoking incidence is very less. Probably that could be the cause of so low incidence of marginal ulcers seen in our series. About the resolution of comorbidities, 89% remission of diabetes at 8 years. And all other comorbidities like hypertension, hyperlipidemia, GERD. Look at GERD, 74% remission of GERD. So mini gastric bypass, which was primarily taken to be as a refluxogenic procedure, is now showing effects like an anti-reflux procedure. Mean operative time is coming down every day. Nowadays we are doing in 30 minutes, but average, if we look back, is 50 minutes. Excess weight loss at 8 years, 79%. When we see the sustainability of the weight loss and look at the other published data like Dr. Lee's report on MGB versus Roux-en-Y, on every aspect, MGB is looking good in the long run. Maintenance of the lost BMI. And in our series, the follow-up has been 76% at 8 years. We do the follow-up either physically or on telephone or email. We make sure that we try to find out each patient and every patient how they are doing. Comparing the data with the other published series, MGB reports from all corners of the world are coming good. Sometimes it looks that the reports are fake. Look at the leak rates, 0.4%, 1%, 1.9%, and then very low mortality and a very good excess weight loss percentage. In our series, there has been a very interesting finding. We do contrast studies on as many patients as possible in the follow-up. And as we see at 8 years, the dilatation of the pouch is not significant. Probably this is because of the wide outlet. We know all the published series are showing good, equal or better weight loss than other routinely performed procedures like Roux-en-Y and laparoscopic sleeve gastrectomy. Again, the only explanation about the sustained weight loss seems to be less dilatation over a period of time. Another recent study by Tolani in SOARD, they looked at the intragastric pressures and the gastroesophageal pressure gradient. They compared in MGB and sleeve. In MGB, the gradient is coming down, so which shows that MGB is a low pressure system because there is no valve at the outlet. Outlet is not tight, unlike a traditional blue and white gastric bypass. It's a wide outlet of 5 centimeters. Probably that is the reason why this procedure is showing a low pressure system inside the gastric tube, and that is the reason probably why it is acting as an anti-reflux procedure, although there were a lot of fears raised in the beginning about the bile reflux, which is not showing a significant incidence in any of the published series from anywhere. So mini gastric bypass represents an effective bariatric procedure. Its safety and minimal postoperative morbidity seems to be remarkable. With that, I will thank you very much. If you have any questions,